All right, this will be Lecture 1B. That's Lecture 1B. Apparently we had a failure in the first lecture. It stopped at this particular slide. Anyhow, we're going to pick up from this slide and continue on. This is slide 44. Slide 44, Chapter 10. Make sure you're logged into Virtual Time Clock to get credit for this. As we were talking about the history taking, very, very important stuff. Being neat and professional, is going to go a long ways as far as gaining the confidence of your patient. If you look like a slob, then you're not going to be very well accepted. Note taking, not a problem with it. Just let the patient know that you're going to take some notes and that you're just, making sure that you're gathering the facts and the information so that you'll have everything to relate to the hospital. Communication techniques, always introducing yourself and your partner, your name, the agency you work for. Be familiar with cultural groups in your area so that you'll know, what could be some of the faux pas that you may be doing, with, being presented, inappropriately to that particular culture. Communicate empathy, offer reassurance, but don't give false hopes at the same time. Making sure that, be very careful what you tell the patients. And sometimes, reassurance can actually harm your credibility. So be poised and confident with a very positive demeanor. Read nonverbal clues, encourage dialogue, avoid medical jargon. You can see whether your patient is truly distressed or not distressed. So look for that. Facial expressions may suggest pain, psychological distresses, or fear. So read your patient. Social history, it's not typically gathered, but it is important, especially if your patient's having certain relative complaints like abdominal complaints, respiratory complaints, that kind of stuff. Alcohol and drug abuse. Obviously, alcohol can mask signs and symptoms as well as other drugs. So be aware, be alert for the smell of alcohol from patient's breath and behavior that may indicate alcohol consumption. Keep professional attitude at the whole time. Patients may give unreliable histories. Obviously, you'll be looking for those kind of clues. Sexual history, talk to the patient in private if we're discussing this. Patients are hesitant to share private or embarrassing information. You need to make sure to establish that trust and keep your questions focused on the need at hand. Physical abuse, domestic abuse, sexual assault, this is one of those required reporting items. Obviously scene safety is number one, but you're going to be looking for clues that indicate, any kind of abuse whatsoever. You're going to report that to the appropriate law enforcement. And obviously don't get yourself in the middle of what you see here. That guy's pretty big. I wouldn't want to tassel with him. Handling physical attraction to patients, just don't do it. You'll end up in court. You'll lose your job. You might lose your license. Just a bad plan of behavior. If these kind of things happen, act professionally. Make sure that you, make it very firm and very clear that your relationship is strictly professional. Encouraging confidentiality. I think we all know about HIPAA. We know our state laws, so you got to keep things confidential. You can only turn this information over to those that are directly related to the patient's care. Interviewing patients while in a private setting, very much so protecting the patient's privacy. Be persistent enough to obtain information that the patient may be reluctant to share, because sometimes it's definitely going to affect your treatment patterns. If patients can't provide information, other sources on the scene. You have third parties, you have police officers, you have caregivers, you have neighbors, any kind of information that you can get from other folks. For routine transfers, if you're doing an interfacility kind of work, look at the patient's chart. Get all the information that you need before you go and introduce yourself so you know what you're dealing with on the type of transfer, because it may not be just routine. It could very much so be a critical transfer as well. Cultural competencies, there's common barriers to communication: race, ethnicity, age, gender, language, education, religion, geography, and economic status. Each one of these are a challenge. You just got to be well prepared for them, and everything runs on a case-by-case basis on how you're going to deal with them. Do respect the ideas and beliefs cross-culturally. Consider dietary practices and family relationships that need to be considered during the patient care itself. Some cultures have an identified leader of the household. You need to make sure that you're addressing that individual to be respectful. Always obtain consent from your patients, as we well know. Provide the best care for all patients regardless of their socioeconomic status. If you are working in a particular area that has a larger cultural group of certain population of people. Make sure you understand what the faux pas are, with working with these kind of folks. Make sure you don't want to do anything to insult them. Facilitating, if you have to use an interpreter, identify that person very right away, in the care of the patient. Consider using closed-ended questions to avoid inexact translations. Remind the interpreter that the information is confidential. A patient's child may be available as an interpreter, but use someone older and less attached to the patient if possible. Special challenges in history taking, overly talkative patients, patient who's silent, patient who's anxious, depression, situational or chronic, and then patients that are angry. Overly talkative, divert the information, try to, after a few minutes, interrupt them and try to get the pertinent information. Patients that are silent, ask open-ended questions and encourage them to communicate with you. Anxious patients, find out what's causing the anxiety and see if you can eliminate it once you walk into the scene. Depression, if it's depression based on, communication problem based on a situation, if you can remove them from that situation, at least temporarily, it might help. Chronic depression, that kind of thing, find out if they've been taking their medications, if there's anything that you can do for them at the moment, and of course you need to get them in to see somebody. Anger and hostility, these can be very, very dangerous type of situations. Don't take it personally at all. Be attentive to the risk, leave yourself a way out or an escape, and then have a very high situational awareness on this. Confusing history or bizarre behavior, consider medical causes. Patient may have a low glucose, so you can very simply do that. Test very, very quickly to find out if that's the case. Patient may be consuming alcohol or drugs. Sensory developmental challenges such as limited education or intelligence, these do happen. You get, with folks that just, haven't had the educational opportunities that maybe we have, so they're a little bit more challenged. And then, of course, patients with hearing loss or low vision or blindness. And we take these again, on a case by case. Pediatric patients, including the child in the history taking process, that makes them much more comfortable, especially if they're that 3 to 5, they're out, or in that beginning of the toddler phase. It'll make them a little less anxious. Make sure that you don't separate from the parents because of the age, the separation anxiety that goes along with that. Be sensitive to the fears of both the child that you're talking to and also the parents, and then pay attention to the parent-child relationship. Tailor your questions to the age. Obviously, neonates 3 to 5, adolescents, those can be the most challenging. Gather the accurate family history as much as you can from the caregiver or the parent. Geriatric patients, they present with a variety of issues, most of them related to their health in general. They have a loss of sensorium and diabetes-related peripheral neuropathy, so they're going to respond quite a bit differently than most of our regular patients do. They're balance and equilibrium problems. They have poor clotting. They have, aged history, maybe disease processes, or, quite frankly, I have seen healthy 94-year-olds running marathons. So you just never know what you're going to get. It all depends on the kind of lifestyle that they've led in their later years. Symptoms may be less dramatic. Consider including functional assessment, the assessment of mobility, upper extremity functions and activities of their daily living. Responsive patients, chief complaint, obviously, why did you call 911? What brings us here to you today? What was the emergency? It should be recorded in the patient's own words. And then, of course, you're looking for clues on the scene, anything that you may see that may be related to the patient's chief complaint. History of illness, we know OPQRST and sample. Make sure that you're using these. OPQRST isn't just for pain, it can also be used for respiratory conditions as well, so don't forget, it has a multifunctional type of use. Again, we talked about why call 911. Patient's behavior may be inappropriate. I would consider hypoxia, any kind of medical issue, or maybe even low glucose problem, psychiatric emergency, or some kind of drug or alcohol involvement. Current health status, made up of unrelated pieces of information. You got to get that pieces of information because they may ultimately relate to whatever the 911 call is about. It ties together with the past history and the history of the current event. And you should be focusing also on environmental and personal habits as well. Some of the examples: what prescription medicines do you take? Are you allergic to anything? Do you drink beer, wine, or cocktails? How often? How much do you consume, in a week? How much do you consume in a day? That kind of thing. And obviously, do you smoke? Because we know that it leads to heart disease. Family history, it gives a good baseline to know what's going on with the patient, so that's helpful. Social histories, patient occupation may lead you to some clues of possible toxic exposures. The environment provides a whole lot of information about the lifestyle of chronic illnesses. So ask those questions. Travel history also may be relevant. Have you traveled to any foreign countries? Were you on any farm pastures? You're looking for potential infectious type of diseases they may have picked up somewhere else. Past medical history should include, current medications, doses, allergies, childhood illnesses, adult illnesses, past surgeries, past hospitalizations, and disabilities. Also, past emotional affect provides insight into overall mental health. We want to be assessing that as well. We want to assess the generality of how the patient feels about life. Do they feel safe within their life, or do they feel unsafe? That's a level of security that all of us should have, and a lot of people don't have that, so it's good to assess that. All right, the last one on this is now moving into the unresponsive patients and how you must rely through head-to-toe physical exam and normal diagnostic tools. With this, we'll let you go ahead and clock out and clock into test 1. That's test 1 of lecture 1, and we'll see you in the next few minutes.